Okay, so I can see on my screen that recording has started. So let's carry on. Okay, so I'll just make the point again now that we've started recording that this session is for Northwest care home staff only, and those who are not in the Northwest may not find it useful. So please do join the national webinars that are going on this week instead. Okay, so in terms of some essentials for this webinar, if you could all please mute your microphones during the presentation. Those of you on Skype, the mute button is at the bottom of your window. Everyone who's registered should have received copies of these slides around lunchtime today. If you haven't received these slides, please give me an email. My email is anna.trelfa, Trelfa, @phe.gov.uk, and I'll send these slides to you after the webinar now. Just to reiterate the point that obviously the situation is really rapidly evolving, and so the content of this webinar is accurate at the time of this presentation, so the afternoon of the 7th of April. But in future, please make sure you are always using the most recent care home pack, the Northwest pack, to inform your local practice. As I've said, we're recording the slideshow, and that file will be available online for 1 week after today's date. The question and answer session at the end won't be recorded, but they'll be captured in an FAQ document and circulated with all delegates afterwards. So feel free to share the Q&A and the recording within your workplaces. Okay, in terms of the format of the session, the first half will be me talking over the slides. As I say, we're going to work through the Northwest Care Home Pack. My name's Anna Trelfa. I'm a specialty registrar in public health, working with the health protection team in Public Health England Northwest. And then the second half of the session, we will have a Q&A session, which will be facilitated by health protection colleagues. And also we've got some brilliant volunteers from our local infection control teams who will help us to field those questions as well. So if you do want to ask a question, if you're on Skype, please type your question into the IM box to the left of the window as your questions arise. For those of you dialing in on the phone, if you could please email your questions to Marav Kleiner. Her email address is highlighted in green, but for those of you on the phone, it is Merav, MERAV, KLINER @phe.gov.uk. If you can share your emails with Marav as they arise, she will be compiling all questions for our question and answer session, and we'll run through those at the end of the presentation. Okay, so this is what we are going to cover during this first part. So by the end of this session, all delegates will be able to describe COVID-19. So that's looking at the virus itself, how it's transmitted, and what the symptoms are. We will be able to understand how care homes can prepare for COVID-19 and how care homes can respond to a single case and also an outbreak of COVID-19 in care homes. Delegates will also be able to facilitate safe transfers into and out of care homes during this period and be able to support colleagues within care homes on how to keep themselves safe and then know where to find further guidance. Okay, so slide 5. So coronaviruses are a large family of viruses. Some of them cause less severe disease, such as the common cold, which we've all had at some point, and some coronaviruses cause much more severe disease. Some of you may remember the SARS illness a while ago, or may have heard of Middle East respiratory syndrome. Those are both coronaviruses as well. This particular coronavirus is called SARS-CoV-2, and it's a new virus, so we don't actually know all that much about population immunity or the virus features. So that means that everyone potentially is susceptible to this virus. In terms of the terminology, so SARS-CoV-2 is the name of the virus, and COVID-19 is the name of the clinical disease. Okay, slide 7. So human-to-human transmission of coronavirus is thought to occur mainly through droplet and contact spread. So this is large respiratory droplets which are generated by coughing or sneezing, and then direct or indirect contact with infected secretions or contaminated surfaces. So that means that if someone sneezes onto a surface perhaps, and then you touch that surface or shake hands with that person, or open that door handle that's been touched by someone with a contaminated hand, and then you then transfer the virus onto your mouth, nose or eyes, then that's how the virus could be transmitted. As well as being in respiratory droplets, SARS-CoV-2 has also been detected in other bodily fluids such as blood, stool, urine and tears. So this means that all secretions and excretions from people with symptoms should be regarded as potentially infectious. Okay, so I've already briefly touched on this. Coughs, and if a person coughs and sneezes onto their hands, or if those droplets land on surrounding surfaces, and then you touch those surfaces and then transfer that virus to your mouth, nose or eyes, that's a good way of becoming infected yourself. Other ways that the virus can be transmitted is through aerosol generating procedures such as tracheostomy care, manual suctioning, chest physiotherapy, or non-invasive ventilation such as CPAP or BiPAP. As I've said, the virus can survive on surfaces, though the amount of surviving virus reduces dramatically after around 72 hours, but it could actually last on surfaces for up to 9 days. The way to inactivate this residual virus is to use bleach-containing solutions or standard detergents on surfaces, and then if it's on your hands, the best way to inactivate this virus is to wash them thoroughly with soap and water for at least 20 seconds, or by using alcohol-based hand gels. Okay, slide 9. So this slide shows the clinical features of COVID-19. On the left there we have the formal case definition. So a confirmed case of COVID-19 is any resident in the care home, or indeed any staff member, who has a confirmed diagnosis of COVID-19 from a laboratory test. So they've been swabbed, it's gone to the lab, and the result has been reported back as being positive. Possible cases of COVID-19 in the care home, again, any resident or indeed staff member who has a new continuous cough, so that's if they're coughing for more than an hour, or if they've experienced 3 or more coughing episodes over the last 24 hours, and they may have that, or they may have a fever, which is a temperature of greater than 37.8 degrees, or they may have both of those two symptoms combined. And that is what we are using as our case definition in the absence of a laboratory test. But in the elderly, there may be a wider presentation of COVID-19 with more atypical features. These are on the right hand side. So those in bold are particular ones to look out for in the elderly. So the bold ones, for those who can't see the slides, are new onset of influenza-like illness, if they experience worsening shortness of breath, or delirium, particularly in those who have known dementia. In terms of if a care home has sort of an outbreak of influenza-like illness, that outbreak should be managed as a COVID-19 outbreak until proven otherwise. So if you think you're starting to see flu-y residents in your care home, then you should be thinking, is this COVID? Okay, but in terms of our initial case, we want to see somebody meeting those criteria on the left. If you have, say, 3 or 4 residents in your care home who are complaining of a headache on one afternoon, that does not mean that there is an outbreak of COVID, just because headache might be a symptom of COVID. Actually, you need at least one person in your care home who's describing, who's meeting the criteria of new cough and fever. And then once you've got that one person, you could then start to look for atypical symptoms, these ones on the right, in your other residents, because that could actually constitute an outbreak. Okay, moving on to slide 10. So this slide shows the more clinical features of COVID. So an incubation period is the time between someone being infected with the virus and then subsequently developing symptoms. With COVID, the incubation period is estimated to be around 5 days, though it has been reported to be as short as 1 day and as long as 11 days. But yeah, on average, it's about 5 days. Mild cases of COVID-19 do tend to recover within a couple of weeks, but more severe cases may take as long as 3 to 6 weeks to recover from the illness. And the hospitalisation rate for COVID-19 is around 8%. That's looking at the whole population. So it ranges from around 2% of people aged under 50 need to be hospitalised, and as many as 44% of those aged over 80 would need to be hospitalised with this disease. So it is quite a high hospitalisation rate, especially in elderly care home residents. Okay, so this slide outlines the general prevention measures. We're on slide 11. Everyone should be familiar with these by now. They've all been hammered home by the daily briefings from the government, and these apply to all of us in our day-to-day life as well as in the care home setting. So self-isolating, just to point out, these links here, they're hyperlinks. So after the session, please feel free to use those links to look at the guidance. So we should be self-isolating. That means staying at home if either yourself or a household member has symptoms of COVID-19, or even if a care home resident develops symptoms, they should be following that self-isolation guidance. Social distancing, that's to reduce the spread of COVID-19, both for us in our day-to-day lives and also for staff and residents in the care home. And then the shielding measure is to prevent those extremely vulnerable people from being exposed to this virus. And if you click again on that hyperlink, you can see the list of people who fall into this extremely vulnerable group. And those 3 general measures should be implemented alongside cough hygiene, so catch it, bin it, kill it, and also frequent hand washing. Okay, so now we come specifically to the Northwest guidance. So the first part of the care home pack is a section dedicated to preparing your care home for COVID-19. So you should be nominating a COVID-19 coordinator for the care home. There should be a coordinator on every single shift, and I'll refer to this role a bit later on in the presentation. You should ensure that your staff are all absolutely up to date with your local infection prevention and control policies in the care home. Deliver or reinforce education for your staff on hand and respiratory hygiene. Another thing is to ensure that your care home has adequate supplies of things like tissues, soap, paper towels, and all the cleaning materials required. Again, to ensure that your care home has adequate supplies of PPE, and we will discuss this in much greater depth later on. Ensure that there are appropriate linen management systems and also clinical waste disposal systems in your care home. And if it's been risk assessed and if it's safe to provide alcohol products in the care home, then please also make sure you have alcohol-based hand gels around the care home setting. And finally, consider how you would isolate any symptomatic residents, either in single bedrooms with the use of an ensuite toilet or provision of a commode for that room, or by using well-ventilated multi-occupancy rooms with designated toilet facilities. Okay, slide 13. So by now everyone should have received a copy of the care home pack. Version 2 was circulated on the 3rd of April, which is Friday, after the pack was bought in line with our national guidance, which was updated on Thursday afternoon. Just to note that the health protection team is planning to review our local care home pack again tomorrow after this webinar to see if it needs any updates. We might actually stick the FAQ section in the care home pack depending on our discussions later on today, and we'll recirculate the pack after that. Okay, so how to respond to a single case of COVID-19. In the first instance, you would contact NHS 111 and receive advice from them on assessment and testing. And if further clinical assessment is advised, you would then contact the patient's GP. That person will then be managed as is clinically appropriate, so as per the advice of 111 or the GP. All symptomatic residents should then be immediately isolated for 14 days from the onset of their symptoms. So when they first developed either a cough, a temperature, or some of those wider atypical symptoms if you've got multiple people in the care home who are unwell. And just to hammer home really that good infection prevention and control practice is absolutely essential to limit the spread of COVID-19. So once you've isolated this person for 14 days, you need to be thinking about implementing additional infection control measures, which we're going to talk about in the following slides. Okay. So if we move on to slide 14, in terms of hygienic disposal, which is referred to here in this middle box, this means that personal waste, so that's any waste that's come into contact with that symptomatic person, so tissues, continence pads, other soiled items, and also PPE that you have been using whilst attending to that person, and the cleaning cloths that have been used in that room, that should all be bagged. And then when that bag is full, you should securely tie it, bag it again, securely tie that second bag, and then put it aside for at least 72 hours away from other waste, and then dispose of that waste as normal. Okay, so on slide 15, we are talking about how to protect other residents when we have a single case of COVID-19 in the care home. So you would need to isolate resident contacts these are people who live in the same unit or the same floor as the infectious case and share the same communal areas, or have spent more than 15 minutes within a 2-meter radius of an infectious case. So those are the people that you need to be isolating. And they should be isolated for 14 days from the date that they were last in contact with the infectious person. And they should be monitored for symptoms throughout this entire isolation period, because they may become unwell with COVID-19. Whilst this isolation is ongoing, care home staff should be implementing infection prevention and control measures under the guidance of your local infection prevention teams, and we're going to cover these measures in much more detail on the coming slides. So first, hand hygiene, or as I've called it here, hand and forearm hygiene. So the best way to practice this is by using soap and water and thoroughly washing for at least 20 seconds between residents and between tasks for the same resident, when you're caring for residents with diarrhea and vomiting, when your hands are visibly dirty, when you can feel a build-up of alcohol gel on your hands at the start and at the end of your shift, before and after breaks, before and after handling waste and dirty laundry, and also before and after cleaning duties. Alcohol hand gel should only be used on hands that are visibly clean, and it should never be used when caring for residents with diarrhea and vomiting. Importantly, hand hygiene doesn't stop at the wrists. It should extend to include washing of the exposed forearms, as it's possible that these may have become contaminated by SARS-CoV-2 whilst you have been performing patient care. So wash your hands, but make sure you also give your forearms a really good scrub as well. Okay, so slide 17 talks about cough etiquette and respiratory hygiene. So you need to avoid hand contact with your eyes, nose and mouth, because as I've already mentioned, that is how the virus is commonly transmitted. When you're coughing and sneezing, cover your nose and mouth with disposable tissues and immediately dispose of them in the nearest waste bin. So that's the catch it, bin it, kill it phrase that we all know. And please do, as I've already said, maintain good hand hygiene, especially after you've coughed or sneezed. Okay, slide 18, and we've got two PPE slides. This is quite a detailed slide, so it might take some time to digest, but I'm hoping that I can work through it with you. So across the top of this table, we have four headers, four columns, and down on the left are the items of PPE that have been recommended for use in North West care homes. So the first scenario would be for a member of staff who is working in a communal care setting. So they're perhaps in a dining room or a lounge, but they're not providing personal care to any residents. They're more than 2 meters away from any residents. In this scenario, care home staff do not need to be requiring gloves and apron because they're not providing personal care, and they are just doing sort of communal care work, such as taking away meals, that sort of thing. But for the purpose of COVID-19, these care home staff do need to be wearing fluid repellent surgical masks whilst working in communal settings. And that fluid repellent surgical mask should be used, should be sessional use. Okay, so that means that once you finish that particular duty in that area, once you finish that session of care, and you leave that area, then you would doff that sessional PPE. So once you leave that setting, you would remove it. Okay, the next scenario to talk about is providing direct care for residents who do not have symptoms of COVID-19. So this could be giving medications, helping with personal care, feeding the person, delivering meals into their bedroom if you do come within 2 meters of that person. Okay, so for these people who do not have symptoms, you should have single use of disposable gloves, single use of disposable apron, and sessional use, again, of that fluid repellent surgical mask. Okay? If you are providing direct care, so that's within a 2 meter radius of residents who do have COVID-19 symptoms, again, it's single use of disposable gloves, single use of disposable plastic aprons, sessional use of the fluid repellent surgical mask. And if there is a risk of coming into contact with respiratory droplets, so for example, if the person is actively coughing, or if there is a risk of splash injury, so that's coming into contact with blood or body fluids, then you would also have sessional use of eye protection. Okay, and the same applies once you have left that care area. So it might be a few single bedrooms with symptomatic coughing people in. Once you finish looking after all those people, then you would take off your sessional PPE. So you'd remove your sessional mask and you'd remove your eye protection. Obviously, you would change your gloves and you would change your apron in between everyone because they are single use only. Okay, the final scenario on this slide is for aerosol generating procedures. So in care homes, this would be things like providing tracheostomy care, suctioning, performing chest physiotherapy or BiPAP or CPAP. For this, the PPE recommendations are slightly different. So single-use disposable gloves are still to be worn, but the mask, a single use of the filtering face piece respirator, that must be worn instead of the surgical mask. Now, to use this mask, you absolutely must be fit test trained. People who have not been fit test trained should not be performing aerosol generating procedures on residents who are coughing, who have symptoms of COVID-19. Okay. Other PPE to use in this situation would be single use of eye protection and single use of a disposable fluid repellent coverall. Okay, so we've spoken about single use versus sessional use. You would also dispose of your PPE straight away if it becomes damaged, soiled or uncomfortable. And if you are using eye protection that is reusable, you would decontaminate that reusable mask, for example, at the point at which you would normally dispose of single-use PPE. And there's a hyperlink there to talk you through how to decontaminate reusable eye protection. Okay, so slide 19, this looks at cleaning PPE. So across the top again, we have 4 scenarios with PPE on the left-hand side. So the first scenario is where a member of staff is cleaning in the same room as a resident who has COVID-19 symptoms, but who is not coughing, okay? So that could be you're cleaning equipment in their bedroom or you're cleaning the room itself. So when the person is not coughing, the risk assessment would indicate that you do not need eye protection. Instead, you would use single-use plastic gloves, single-use disposable apron, and sessional use fluid repellent surgical mask. Okay, moving on to cleaning in the same room as a resident who has symptoms of COVID-19, but they are actively coughing. So in that scenario, you would need eye protection because your risk assessment means that you may be coming into contact with respiratory droplets. Okay, so the eye protection is indicated, sessional use only, as well as the fluid repellent surgical mask. Again, that's sessional use. And then gloves and apron are indicated, but single use only. Okay, so the third column is cleaning a contaminated environment. So an example of this might be cleaning the shared bathroom, which is being used by cohorted residents, so a group of residents who have symptoms but do not have access to en-suite bathrooms. Okay, so to clean this designated bathroom, you would want to use disposable gloves, disposable apron, single use for those. And you would want to use sessional use of a fluid repellent surgical mask, and you would use eye protection, but only if there is a risk of a splash with, for example, body fluids. If there's body fluids in the bathroom or blood, that sort of thing, that's when you would use eye protection. But if there's no risk of that, for this scenario, you don't need eye protection. So that's a judgment on that particular scenario. And finally, the last column is cleaning in a non-contaminated environment. So this is just general cleaning, perhaps in communal areas not used by symptomatic residents or bedrooms of people who do not have symptoms. And again, you would use disposable gloves and disposable apron, single use of both, and sessional use of the fluid repellent surgical mask. Okay. So yeah, please do spend some time focusing in on slides 18 and slides 19. This is slightly different to what's in the care home pack as it stands presently. There has been a slight change in the interpretation and our recommendation for implementing the national guidance. So when the pack is updated and recirculated, it will include this guidance, okay? All right, so slide 20, this is a video of how to don and doff PPE in social care settings. It's a Public Health England video. I'm not actually going to play it now. It's about 6 or 7 minutes long, but I strongly encourage you to come back to slide 20 and watch the video straight after the webinar. Okay, slide 21. So these are some of the more frequent PPE questions that infection control nurses seem to be getting. So I thought that we could cover them here whilst we've got everyone on the phone. So the first is, do I need to wear PPE for the direct care of every resident? And as we've just discussed on the previous slides, you should be wearing disposable gloves, disposable plastic apron, and a fluid repellent surgical mask for the direct care of every resident. Eye protection is only indicated if the resident you are caring for is actively coughing or if they present a splash risk. So that's accidental spraying of body fluids into the eyes, for example, urine, blood, that sort of thing. Okay, when should I be wearing a mask? The new guidance indicates that care home staff should always be wearing a mask whilst in the care setting. For the most part, this involves the sessional use of a fluid repellent surgical mask as per the tables on the earlier slides. Only where you're performing an aerosol generating procedure should you wear a different mask. So that's the special filtering face piece respirator mask. And you should not be wearing that unless you have been fit test trained. So only those who have undergone that fit test training should be performing aerosol generating procedures in the care homes. Okay, slide 22 explains what sessional use of PPE is. I've already touched on this a little bit, but just to kind of go into the intricacies of it. If a worker is caring for symptomatic residents or residents who have tested positive for COVID-19 in the same area, for example, a multi-occupancy room, or an area with multiple single bedrooms where people have symptoms, they should wear sessional PPE for that care session or that period where they are providing care to those people. Once they have finished that series of tasks in that care area, they should then dispose or doff their sessional PPE. Or if it becomes damaged, soiled, uncomfortable, as we mentioned before, that PPE should also be removed before and after breaks. Okay. Once the carer returns to that care area, they should put on new sessional PPE, as well as obviously the single-use plastic gloves and aprons. So that's talking about symptomatic patients. You should also wear sessional PPE for the care of asymptomatic residents, and that PPE should not be the PPE that you've used for your symptomatic people. So to avoid that crossover, where possible, one group of staff ideally should be caring for symptomatic residents only. And those staff should care for the kind of possible cases first, so ones where they don't have a lab diagnosis. So do all of those first, and then once you've finished the care for those people, move on to people where you know, yes, this is definitely COVID-19, I've got a lab confirmation. So yeah, the suspected people first, and then the confirmed people last. And then another group of staff should care for asymptomatic people only, again just to avoid that mixing and crossover. Okay, slide 23, some more PPE questions. A common one is, why do I have to wash my forearms? Again, we've already touched on this, but it's possible that your forearms may have become contaminated with the virus whilst performing patient care. So that's why you need to perform hand hygiene all the way up to your elbow. Your forearms should not be covered by long sleeves, and they should be free of jewellery. So that's known as being bare below the elbow, though one plain metal ring is permitted. Your nails should be short and free. They shouldn't have false nails on your nails. Okay, a common question as well is, how do I order more PPE? So there are 4 distributors listed here. These are in the Northwest pack. So there's contact numbers in the pack as well. There are also email addresses. So please do reach out to those providers, those distributors in the first instance. But if you have immediate concerns over your supply of PPE, then you should be contacting the 24/7 supply disruption line. And that phone number is listed there on the slide. For those who don't have slides, it's 0800 915 9964. However, to conserve your stocks of PPE, you really should be considering bundling your activities to minimise the number of times that a room needs to be entered. Obviously, that needs to be within safe limits, but if that means that you only use one lot of PPE, then that's much better in the long run. Obviously, though, we recognise that it's not appropriate for care home staff to be seeing symptomatic residents without PPE. PPE is there to protect you, and it's there to protect the other residents. But equally, it's not appropriate for you not to see residents that require care. So it is therefore really important to forward plan for your PPE supplies and escalate any supply issues in a timely manner, in the first instance with those 4 distributors, and then to the 24/7 national line if you've got any other concerns. There are kind of reserve stocks around the region, but there may be a bit of coordinating required in order to access those, and they are sort of last, the last option. So in the first instance, please do forward plan and also bundle your activities. Okay, slide 24 is touches on environmental cleaning. So in addition to all the regular cleaning that's going on, communal contact surfaces, so that's door handles, grab rails, remote controls, that sort of thing, should be cleaned at least 4 times a day. To make your life easier, it's probably best to remove things like magazines, soft furnishings from communal areas. In terms of cleaning rooms that have been inhabited by people who have symptoms, ideally, that cleaning should be undertaken by staff who are providing care to that person to minimise the number of people who are going in and out of that room and to minimise PPE usage. But obviously, that's not always possible. So domestic staff can clean the isolation room, but that should be done once all other unaffected areas of the care home have been cleaned. Remember that domestic staff should also be wearing PPE as outlined in the earlier tables. Okay, in terms of reusable equipment, non-invasive care equipment like blood pressure monitors, thermometers, that sort of thing, they should all be cleaned and disinfected before they are removed from the isolation room. How to clean, so you would be using disposable cloths, paper roll or disposable mop heads for all your surfaces, and you need to use either a combined detergent disinfectant solution of 1,000 parts per million chlorine, or you can use a neutral purpose detergent followed by disinfection. And you should be following the manufacturer's instructions for how to use those, how long the contact time is, etc. And once you've finished, your cloths and mop heads should be disposed of as they are single-use items. Okay, slide 26 talks about waste disposal. We've already touched on it a little bit earlier on, but just to mention that waste disposal should be compliant with this HTA 7.1 guidance. That is a hyperlink, so again, after the seminar, please feel free to have a look at that. We've spoken about double bagging, so I won't go over that again. Just to note that waste like urine or feces from people with symptoms don't require special treatment and they can just be flushed down the toilet as normal. Okay, slide 27 just talks about some additional measures. So if it is absolutely necessary to move a symptomatic resident, you can't avoid it, then that person should be wearing a surgical mask for their move through the care home. That's to avoid spreading or coughing and putting out respiratory droplets. Importantly, you should consider ordering your activities so that well residents are seen to first and then move on to symptomatic residents. So some examples of this would be to give meals to well residents first, to clean the rooms of symptomatic residents last, and if you've been allocated to care for symptomatic residents only, then like I've already said, you would care for the possible cases first, so that's where there has not been a laboratory test result but they are displaying symptoms, so look after them first and then move on to those who you know they definitely have COVID-19 because they've tested positive. Okay, so in terms of declaring a suspected outbreak, we can manage a single case. How do we manage an outbreak? So to declare an outbreak, you need to have 2 or more cases which meet the clinical case definition, and those cases must have arisen within the same 14-day period, and they must be within people who work or live in that care home. Remember that you must have one person who has the cough or the fever or a positive result before you start thinking about those more atypical symptoms such as shortness of breath or delirium. Okay, so what do you do when you think we've got an outbreak in the care home? You need to report it via these channels. So 9 to 5, Monday to Friday, you would pick up the phone and speak to your local infection prevention and control team. If you're in Cumbria and Lancashire, you should actually pick up the phone and speak to us at the health protection team. Discussions are ongoing at the moment around alternative arrangements, but that is the current situation. You would speak to us first. And then out of hours, everyone across the Northwest should be reporting their suspected outbreaks to us at the health protection team, following the numbers on the slide here, and they're also in the care pack. Okay, slide 30 outlines the response to an outbreak. So if you do suspect an outbreak, care home staff should, as with a single case, discuss the symptomatic residents with 111 and or the GP, because clinical assessment might be required for those people. You should inform the local infection prevention control team, as I've already said, or us at the health protection team, and we will, or the infection control team, will advise on infection prevention and control measures. Then the care home staff obviously will be implementing and adhering to those measures, as well as implementing social distancing measures for everybody in the care home. And for those who fit into the extremely vulnerable group, they should be shielded, so kept in their bedroom, well away from anyone with symptoms. Okay, then you need to implement regular monitoring for symptoms amongst residents and care home staff. So residents should be assessed twice a day, at least, looking for fever or new respiratory symptoms. And if you pick up any of those or any other sort of atypical symptoms, you should immediately report these new suspected cases to 111 or the GP. Okay, so moving on to slide 31, the next step would be for the COVID-19 outbreak coordinator, who I spoke about earlier, to complete the daily logs in our Northwest Care Pack and to liaise with other partners to ensure effective outbreak management. So those other partners are the infection prevention and control team, people within the local authority. There will be a named person within the local authority to speak with, and us at health protection. Okay, you would keep that person, the outbreak coordinator, would keep a daily log of suspected and confirmed cases, and that log is action card 7 in our Northwest Pack. Using that log, you would provide accurate information to us or the infection control team, and you would implement any ongoing advice. If swabbing or testing is available in your locality, as indeed it is in a handful of places across the Northwest, you may be advised that swabbing should take place, and you should follow that advice as it's given. And this is a sort of loop that continues on and on and on, that liaison between the care home, the infection prevention and control team, and us in the health protection team until the outbreak is declared over. Okay, so common outbreak questions on slide 32. A common question that infection prevention and control nurses are being asked is, how do we manage the expectations of relatives and visitors who want to visit the care home? So obviously restricting visitors is part of that wider social distancing advice that I touched on earlier. I've pulled this from the Dementia UK website and also the British Geriatric Society website, but they have a couple of tips about ways in which you can explain the current situation and reassure relatives why those isolation measures are in place. It is to prevent the spread of coronavirus from outside the home to within the home, and also between residents of the home. You can schedule phone calls, FaceTime sessions, that sort of thing. So please do feel free to click on those hyperlinks and explore that in your own time. Okay, another question that ICNs are asked is, how do we manage visitors for residents who are approaching the end of their life? We are still waiting further guidance on this, but in the meantime we would suggest that family members are shown how to use PPE and they are supervised when they wash their hands as they leave the room. That's whilst the resident is still alive and also after the resident has passed away. And you should continue to communicate with mortuaries in the same way. They will obviously need to know that the death is suspected to have been due to COVID-19 infection, or indeed if the person has had a positive result. Okay, slide 34 talks about cohorting. So what is cohorting? So cohorting is a very effective infection prevention and control strategy for the care of large numbers of unwell people, and it's where a group of residents, all who have symptoms, are housed in the same multi-occupancy room or within the same unit. But importantly, people who have suspected COVID-19 should only be cohorted with people who also have suspected COVID-19. Those who have suspected COVID-19 should absolutely not be cohorted with residents who have had a positive test. Try and keep them as far apart as possible. And even more importantly, both suspected and confirmed residents should not be cohorted next to residents who are immunocompromised. As well as cohorting people who have symptoms, you can also cohort contacts, so people who have had contact with the symptomatic case, they can be cohorted together if single room isolation isn't possible. And then finally, you can also cohort residents who've had no contact at all with the symptomatic person. They could perhaps be housed separately in another unit, so cohorted away from the cases and away from the exposed contacts if that is possible. Obviously, I recognise that's not always possible. And then, as I've mentioned, extremely vulnerable residents should stay in a single room and they should not share bathrooms with other residents. So they should either use their ensuite or they should have a designated toilet for their use only. Okay, slide 35, really tricky one. How do we isolate residents who wander? Again, this information is taken from the British Geriatric Society, so feel free to explore that hyperlink in your own time. So we recognise that in some situations we can't isolate, and it's these scenarios where cohorting can be very beneficial where it is possible. So that would be a designated sort of symptomatic area where symptomatic wandering residents can walk around, but because everyone has symptoms, it's sort of less of a risk, and then you could have a closed off separate area for asymptomatic people, okay, to avoid mixing between the two. But where possible, care homes should really seek advice and work with dementia teams and community mental health teams on how to modify the behaviour of wandering residents. This is not our specialty in health protection, so please do seek that advice from your local experts. Okay, moving on to transfers. So slide 36 talks about admission from care home into a hospital. So someone who has symptoms of COVID-19 or has been confirmed as having COVID-19 and then need to go to hospital. So what you would do is you would obviously phone ahead and tell the hospital, and you would also tell the ambulance prior to transfer that you have a resident who has symptoms. And you would obviously postpone all the non-urgent appointments and transfers. Slide 37 talks about a resident who does not have symptoms of COVID-19. They need to go to hospital, but they've been transferred from a care home that does have COVID-19 in the care home. There is an outbreak. So exactly the same principles apply. You would tell the hospital and the ambulance, we've got an outbreak in the care home. This person doesn't have symptoms, but they need to go to hospital. And that will allow the ambulance and the hospital to implement appropriate measures. Okay, slide 38 talks about discharging from the care home back to someone's own home. So say, for example, the person has symptoms of COVID-19 and they're being sent home. So if they've not yet completed 14 days of isolation from the day that they first started with symptoms, they can finish that isolation period in their own home. When they're going home, they should wear a mask and they should be in a private car. If they live with anyone at home, they should isolate themselves from 14 days from the day that that person returns home. Okay, slide 39 touches on transfers or discharges from the hospital back into the care home. So the national guidance states that hospitals around the country need as many beds as possible to treat an increasing number of COVID cases, and that means that the NHS will be seeking to discharge more patients into care homes for their recovery. But there are a few principles to be aware of. So where possible, transfers of patients with possible or confirmed COVID into a care home should be avoided, especially if the care home is struggling to implement full infection prevention and control measures. It's particularly important to consider if the care home does not have an ongoing outbreak of COVID-19, but equally, Transfer of asymptomatic patients into a care home where there is COVID-19 should also be avoided, but these are all where it is possible, and obviously it's not always possible to avoid those discharges. So if it isn't possible to avoid admission back into the care home, the person should be cared for in isolation. So again, ideally in a single room or cohorted. That person should not leave the room for 14 days after their symptoms started, and the staff should wear PPE whilst caring for that person. If you have contacts in the care home who are already in isolation for another reason, for example, if you've got other symptomatic cases in the care home, those contacts don't actually need to extend their isolation period when the new person is admitted back into the care home. Okay, slide 41. So, regardless whether or not there is an outbreak of COVID-19 in the care home or not, the person still must be medically fit for discharge, though they may still have symptoms, and those infection prevention and control measures must be implemented for that whole 2-week period after their symptoms started. Something to note, the national guidance states that it's not necessary to have a negative result before the person is discharged back into the care home. The hospital will inform the care home of any COVID-19 issues, so that's things like when their symptoms started, when they tested positive, and that will help to inform how long that 14 days of isolation should be. And the hospital will also provide a care plan for discharge. Okay, so let's have a look at some scenarios. So transferring, a patient who does not have COVID symptoms, who's being discharged back into your care home, and your care home does not have an outbreak, and that's fine, they can be discharged back, but you should monitor for symptoms for that first 14 days. If the symptoms do occur, then you should then start isolation, okay, for 14 days, and then wear PPE and speak with the GP. Slide 43 outlines a situation for a resident who has tested positive for COVID-19. They're in hospital, they're no longer showing symptoms, and they've completed 14 days of isolation, and they're being discharged back to your care home where you do not have an outbreak. That's fine, you can admit those people and provide care as normal. They've completed their isolation period. On slide 44, we're talking about a resident who was previously tested positive for COVID-19, and again, they're no longer showing symptoms, but they've not yet completed their 2 weeks of isolation, and you're coming back to your care home where you do not have an outbreak. So these are the admissions that I spoke about where possible. These transfers of COVID-19 patients into a COVID-free care home should be avoided. But if you're unable to avoid that admission, then you should provide care in isolation for those 14 days after that person started with symptoms. Wear PPE and think about sending them back to hospital only if clinically indicated, so only if the GP suggests that's the right thing to do. Okay, slide 45 talks about a resident who does not have symptoms of COVID, so no cough, no fever, and they're being discharged from hospital back to a care home that does have COVID-19 in the care home. So again, where possible, transfers of asymptomatic people back into a care home with COVID should be avoided, but that's not always possible to avoid those transfers. So in those circumstances, strict infection control precautions should be in place, and the resident should be isolated with other asymptomatic people away from the symptomatic people in the care home. Importantly, anyone who's been in hospital and they've been in a bay with COVID-19 people in hospital, so someone who's had a positive result, those exposed residents, when they return back to the care home, they should isolate in the care home for the remainder of their 14 days. Okay, so there's a lot of sort of where possible do this, where possible do that. We recognise that it's not always possible to avoid those admissions. The wider system is looking into kind of alternative ways of facilitating rapid but safe discharge of those people. I don't have an answer on that yet, but hopefully with those discussions going on in the background, things will become clearer over the coming days and weeks. But if you could follow the advice on these slides when you're faced with these situations. Okay, slide 46 briefly touches on testing. So the NHS England, NHS Improvement Northwest is leading on this, and they are currently prioritising tests for those who require hospital care and also for NHS staff. Over the kind of coming days and weeks, that capacity for testing will be increased, and wider health and social care staff will be included as that expands. But regarding outbreaks in care homes, the eventual plan would be for community testing hubs in the Northwest to do sort of outreach testing in care home settings. But obviously that in a lot of places, those community testing hubs don't currently exist. And NHS England, NHS Improvement are looking into other ways of testing in care homes. But in the meantime, if there are systems in place locally where your care home is to get that test done, then please do go ahead. PHE will support that testing where those arrangements are already in place. Okay, slide 47 touches on care home staff. So staff who come into contact with a resident who has symptoms and that staff member is not wearing PPE at the time, they can remain at work because in most instances that will have been a short-lived exposure. However, if a staff member starts to show COVID-19 symptoms themselves, so remember that's the cough and or the fever, they should stay at home off work for 7 days from the day that their symptoms started. If someone in your house develops symptoms, then you have to isolate for 14 days from the day that that person became ill. So the first person, that's when your 14-day isolation starts. If anyone else in your house develops symptoms during that 14 days, you still work to the first day of the first ill person. That's when your 14-day clock starts. If you then develop symptoms during that 2-week isolation period, your 7-day clock starts. So you have to isolate for 7 days and then you can go back to work if you're well enough after that 7-day period has finished. And care homes should have business continuity policies in place to protect against high levels of staff sickness. Okay, slide 48 just shows a signpost you really to some further guidance. So again, I encourage you to browse those in your own time. Brilliant. So you are going to be sent an email following this webinar, and the email will include a link with a short evaluation. If you're watching this webinar with colleagues, please do forward the link to them so that they can complete it too. And once you've given us your feedback, which will be much appreciated, you will then be sent a certificate of attendance. So thank you very much for dialing into this session today. Okay, so now what I'm going to do is I'm going to stop the recording of the session, and we're going to work through the questions that have been sent to us via email and also using the Skype messenger function. I can hear that loads of questions have been coming through whilst we've been on the call. So what's been done whilst those questions have been coming in is my colleague Marav has been compiling them together. So questions around the same theme will be grouped together and answered in one go to completely cover that topic area. So your individual question may not be answered, but the general area will be talked about. What I'll do is I'll read out the name of the question, the name of the person who shared that question, and then read out their question. Please, if you're still on the line, unmute your microphone and feel free to expand on that, and if you want to be part of the discussion. But once you've finished, please do remember to mute your microphone again, so that we can minimize background noise and move on so everyone else can hear the remaining discussion. Okay, so I'm just going to stop the recording.